Welcome to this edition of AFMC.
I'll tell you how I got better. I'm
Glad to be here.
A mission to
Delivery of Well, I think that we're going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Dr. Lee Archer, and he is a professor of neurology at UAMS. Dr. Archer, thanks for being here.
Thank you. It's good to be here.
So we're talking about multiple sclerosis, which is your specialty. Tell me about your approach to treating MS.
Well, I think the approach would be deciding how strong a medication somebody needs at the outset, because people present with very mild cases and people present with a very devastating situation. And so we're lucky that we have a gradation of treatments, that some very mild with very little impact on the immune system and some with profound impacts. And so the real trick, I think, is deciding which medication to start with when somebody first presents.
And has there been significant changes in treatments, or has it been kind of the same cookie cutter kind of set of treatments over the last?
It's tremendously different. When I started in the mid-'80s, we had no treatment except symptomatic treatment. We treated people for pain, spasms. If they were weak, we helped them get a cane, a wheelchair. And it wasn't until the mid-'90s that we got the first treatment. And then since then, the treatment has just exploded. And now we have extremely effective treatments that I talk to patients about being on cruise control. You're on treatment, you come see me, it's more of a social call because everything's stable, their MRI is stable. And so we're at a very good point right now with MS treatment. We don't have a cure, but the treatments generally, we can keep somebody stable.
You say no cure. Is research on the horizon? Do you think that will happen?
It will. It's not going to be soon. But our treatments are so good now that we're in a good place.
And what are the most effective treatments available for MS patients today? You said it's medication. And what does that look like?
So there's an IV medicine that's kind of one of the top of the line treatments called ocrelizumab. And it selectively kills a group of lymphocytes in the bloodstream. That group of lymphocytes makes antibodies. They're part of the group that make antibodies. And when you knock those out, it reduces the effectiveness of the immune system in such a way that MS is typically well controlled. So there's that. And then there's an IV medicine, Tysabri, and it is used once a month. Ocrelizumab is used every 6 months, Tysabri monthly, and it works in a different way. It blocks the ability of cells to attach to the side of a capillary and get into the brain. And when they can't circulate through the brain, then they can't do the damage that MS does to the central nervous system. And then there are oral medicines that work in different ways to suppress the immune system. Dimethyl fumarate is one, taken twice a day. Teriflunomide is one that's taken once a day. Gilenya, which is fingolimod, it's taken once a day. And they work in different ways to suppress the immune system with different degrees of severity. Different side effects. And so we've got a lot of options, a lot of things that we can choose from.
And understanding the current treatment landscape is so important. And MS treatments can vary. You mentioned based on the patient's needs. So is there an age factor? Is there different types of MS that kind of come into play?
Yes. MS has several different types. One type we refer to as benign because it's so mild. And usually we can't diagnose that unless some time has passed. If somebody comes to me and they had optic neuritis 10 years ago, and 15 years ago they had an arm that wouldn't work, and then they got over it, and then now I'm diagnosing them with MS, and they have no disability, I'd say, well, you've had MS, but it's been so mild, then we don't need to use anything strong. maybe we don't have to use anything at all. I have some people that it's so mild, they don't want to take anything, or I don't want to give them anything because it's so mild. So we refer to that as benign. The most common way people present is with relapsing remitting MS. They have an attack. And the attacks are in the white matter of the brain or spinal cord, and they cause neurological symptoms. And that depends on where it is in the nervous system. And it can be all different degrees of severity. If it's in the spinal cord, somebody might have paraplegia and have trouble walking. And again, the symptom can be all degrees of severity, and the permanence of the symptom can also be all different degrees of severity. Some people, they don't get a lot better after the first attack. Most people do. And most people respond well to steroids when we give them for that first attack. So we have relapsing remitting, and then we have relapsing progressive. And actually the majority of people after relapsing remitting over a period of years, they turn into relapsing progressive, and they start gradually getting worse. And we don't fully understand the relationship between relapsing remitting and relapsing progressive. The relapsing remitting is in the white matter, and the progressive symptoms are in the gray matter. And you would think they're related in that if one is severe, the other will be severe, but they're not. There's no correlation between how severe one is and how severe the other can be. So that's part of the mystery that's going to have to be explained when we finally get an answer for MS.
So we could see why it's even more complicated to treat.
It is. It is. And people with the progressive MS, there's a different set of medications. The relapsing remitting medicines don't tend to work as well as a rule.
And what role do lifestyle changes play into treating MS?
Good question. I do have an OBGYN doctor with MS. And when he first presented, his symptoms were not severe, and he kept staying up all night, delivering babies, pushing himself, running on adrenaline, and he kept having attacks despite being on treatment. And I said, you're going to have to quit. You're going to have to quit delivering babies at night. And when he did, and he just practiced gynecology during the day, his MS got a lot better. Stress can make people worse. High levels of stress especially can precipitate MS. So we tell people about that. Try not to put too much stress on yourself. Get regular sleep, enjoy life, regular meals, regular exercise, the stuff all of us are supposed to do.
Can you explain the different types of the disease-modifying therapies and how they might benefit someone with MS in different stages?
So with the relapsing remitting, if somebody has minor symptoms, for instance, sometimes people have an MRI scan for migraines, and we see lesions that are consistent with multiple sclerosis. And then we start asking questions. You ever have numbness somewhere? And they say, yeah, my leg went numb, last year. And we say, it looks like you have MS. Maybe we look at their spinal fluid and we say, yes, you've got MS. Then probably we would use a very mild medication. There are medicines like teriflunomide that I mentioned earlier, once a day medicine, that it doesn't make it easier to get cancer or infections. So it's a relatively mild immune modulating drug. And so that would be ideal for somebody that has a mild case. But then we say, okay, somebody presents with paraplegia and they don't get better, and they have a lot of spots in their brain or their spinal cord. Then we may use something that's a lot stronger, like the IV medicines, every month or every 6 months, because we want something that's going to not allow any more of these attacks that so far have been pretty devastating.
And what tests or scans do you rely on to monitor MS regression?
MRI pretty much exclusively. Now, initially, we always do it with and without contrast, because an active lesion, a lesion that's present or just started, it's going to enhance with contrast because there's more blood flow. Contrast goes where blood flow goes. And so if you see an enhancing lesion, you know it's active right now. It's causing irritation right now. But as time goes by, typically I don't do the scans with contrast because the scan is typically stable. And a new spot means the same thing to management, whether it enhances or not. And we don't know if we give the contrast every year for 30 years, if it has an adverse effect. We don't think so. But in my mind, if it's not going to make a big difference in their management, I don't typically do the contrast after the first few scans.
So you're not looking to where you have to do it one every year or every 6 months?
Correct. The first 10 years, usually I'll do it once a year. I will. But then we'll start spacing it out if someone's stable.
And how do you differentiate between relapsing, remitting MS and progressive forms of MS in terms of treatment? There is a difference.
There is. With the relapsing, remitting, the medicines I mentioned can all be used. With the progressive form, the IV medicines like Tysabri given once a month and the every 6 month ocrelizumab, they would tend to be effective for the progressive form.
And you talked about follow-up or doing an MRI, say once a year over a 10-year window. What does the monitoring and adjustment look like for a patient once they're diagnosed?
Well, hopefully we've been blessed, smart, lucky, and we've chosen the right medicine. And then we're just seeing stable scans and stable symptoms. So that's what we want. We want no evidence for disease activity over time. And if there is, then there's a judgment call. Well, she had a patient recently that had one new small lesion over like 4 years. And so she and I agreed, let's leave it the same. Let's not change. We've done real well for a long time, and we have one small new lesion. Let's just watch you on the same medicine for now. So it really depends. Obviously, somebody has, in the first year, they have 3 new spots on their brain and a new symptom. We got to change. We've got to do something stronger in order to control the disease.
And what do you want the healthcare community, particularly PCPs, to know if they have a patient? What should they look for before they get to you?
Well, MRI scan is kind of the examination of choice, and it's pretty widely available. And so in young adults with neurological symptoms, the number one cause is MS, except for trauma. So if somebody has no history of trauma, new neurological symptoms, we think MS first. And they're trained, and they know that. And so getting an MRI scan, looking for it, and perhaps the main advice I would say is have a low threshold for checking an MRI. If somebody has some numbness in their leg and you don't have a good explanation for it, let's go ahead and see. Let's go ahead and make sure that they don't have MS with a scan, because earlier treatment's better. The earlier you treat, the better you are at preventing disability later on.
And what inspired you to specialize in MS? I know that it is your passion and what you treat the most.
Mm-hmm. So, great question. Early in my career, representatives from the National MS Society came to see me, and they said, nobody else in Arkansas has this as their specialty. Would you do that? And so, so I did. I said, okay. And then the next question would be, well, what keeps you coming back? And the people are so nice, so the families of people with MS, I don't know. I connect with them. They are so nice, pleasant, appreciative, and so it just keeps me coming back. It makes every day a good day.
And tell us about your work at UAMS. So your specialty is MS. And you recently had a symposium about it too. Tell us a little bit about the symposium and what does that entail?
It was organized by two of the PhDs at UAMS, Crystal Fullen, who's a neuropsychologist, and then a neurobiologist, Ashley Pike. And they wanted to do it, organize it. They did all the work. And we had not had a symposium for MS patients in a while. COVID really put a monkey wrench in everything. And they did a great job. I had several neurologists from the community, including me, physical therapists, neuropsychologists, at pharmacy, and a patient kind of gave her presentation about her journey with MS. And so it was a great event where people got to see each other. I think we had close to 100 people online, on site, and at least an equal number online. So it was a very successful event, a lot of good information. MS Society came and had a booth. The Rampy Foundation that raises money for MS research from Northwest Arkansas, they came, had a booth. So it was a lot of fun, very successful.
So there are resources out there for the healthcare community and for patients or those that have been diagnosed for MS. What do you suggest? Where do they start?
The National MS Society has a fabulous website, and you can trust everything that's on that website. It's vetted by the best experts in the field. And so I encourage people to look at that website. They can pretty much get any answer they want from nmss.org, National MS Society. So I encourage that. They also have an 800 number, 1-800-FIGHT-MS, and they've got a bank of people answering questions on virtually any question that somebody has. So I encourage people to look at that website for up-to-date information.
Well, Dr. Archer, thank you for talking about this important information and for all that you do for those in the state of Arkansas.
Robin, thank you. It's been a pleasure.
And that's it for this episode of AFMC TV. Thanks for watching and have a great day.